Hello, everyone. On behalf of the ASCP, I'd like to welcome you to the fifth Building Bridges webinar in this series. This series seeks to unite the greater laboratory and pathology community to share best practices for topics that affect us all. Next slide, please. I'll start by introducing myself. My name is Michele Campbell. I'm going to serve as your moderator today. I'm a senior principal developer in the Department of Laboratory Medicine and Pathology at Mayo Clinic in Rochester, Minnesota, as well as an educator of the next generation of laboratory professionals at the University of North Carolina at Chapel Hill. I also have the pleasure of serving you as a member-at-large director on the ASCP Board of Directors. Welcome. Next slide, please. Today's session, Empowering Patients and Families, focuses on strengthening the human side of laboratory medicine by providing participants with thoughtfully designed tools and resources that foster compassionate communication and clear conversations about laboratory testing and results. This session highlights strategies that help clinicians, laboratorians, patients, and their families navigate complex information with confidence and empathy. Together, we're going to explore approaches for shared understanding, reducing confusion or anxiety around test results, and building trust through transparent, supportive dialogue that honors each patient's needs and circumstances. Couple housekeeping items. The session recording, today's slides, and additional resources will be available on our website in about 2 weeks. For questions, please use the Q&A function at the bottom of your screen, and we will have a Q&A component of the webinar at the end of our time together today. Finally, continuing education will be available for all live attendees of today's webinar and is available to claim within 1 month of today's live session. Please expect an email tomorrow with details for claiming credit. And with that, I'd like to ask our first panelist, Ms. Courtney Campbell, to go ahead and introduce herself and get us started.
Good afternoon, everyone. My name is Courtney Campbell. I'm here representing the patient side of things here. In addition to some other folks, we'll have give you guys some information about what they have going on and what we can all do. So I am 38 years old. When in 2016, I was diagnosed with myasthenia gravis. Now, that was kind of a story in and of itself. I went the route that a lot of people end up going who have autoimmune issues, chronic illnesses. I was diagnosed from a crisis. So I went to the urgent care. I was, walking, talking. Everything's fine. I explained to the young lady at the desk, hi, last night I fell forward and I felt a cracking in my chest and my neck kind of hurts. So if anyone has seen any form of any medical show, you guys know that the combination of I fell forward on my neck and it's kind of hard to hold my head up, I got very popular very quickly, as you can imagine. So, rushed me to the back immediately with the cervical collar because, of course, main thought was, oh my gosh, she's broken her neck. So we go in, do all the good stuff. And there was a situation that particularly stands out in my memory. A nurse came in with the O2 monitor. So, regular standard, come in, check your O2 stats, leave. She came in, she checked my O2 stats, and she made this kind of face. And she said, I'll be right back. I said, okay. So she goes, a couple minutes, comes back, presumably with a different machine. She tests it again. I get the same face. Now there's a problem, and now y'all aren't saying it. No one's saying it. So she leaves again. This time she comes back with someone in a white coat. Yep. She, oh, I'm sorry. Are we having a technical issue? No?
I hear you just fine.
Okay. Thank you. I apologize. Um, so when she comes back again, she comes back with someone in a white coat. So she does it again, O2 monitor, and this time she doesn't look. She shows it to the person she brought back in the white coat. Everybody stopped. Immediately lay her down. We have to get imaging. We have to. So what I learned later on was that at that point, my O2 sats were about 66, 67%. And medically, I probably shouldn't have been upright. So, that was the beginning of my story. Fast forward, I was put on a ventilator and sent to Piedmont Henry, at which point I was then transferred to Piedmont Atlanta because no one knew. I spent 3 weeks in the ICU at Piedmont Atlanta, where I saw, I think, every neurologist, pulmonologist, any rheumatologist, endocrinologists that Kaiser has. I was in the intensive care 3 weeks. We saw everyone. Finally, a test that took 2.5 weeks of the 3-week stay confirmed the myasthenia gravis and that I had the anti-MuSK positive variation. So that year was rough. No one in my family had ever had an autoimmune disease that we knew of. No one knew what to expect at all. So we were really just by the seat of our pants here. Towards the end of 2016, I had come back from Christmas with my family. They had, big family Christmas, all that good stuff. It was my first day back to work. I got to my lunch break. I called my mom. I said, Mom, I don't know what's going on, but something is wrong. And that's one of the things that I'll touch on quite a bit later. Your support system, the people you have around you, including doctors, nurses, techs, CNAs, janitorial, everyone plays a part. So I called her, I said, Mom, something wrong. She immediately came to get me, took me to the hospital. I was in the ER and they had taken me back. And my doctor, well, she wasn't my doctor at the time, but she was the doctor on call in the emergency room, Dr. Hazariwala. She came in and she did an ABG. That is an arterial blood gas. It hurts a lot, in case anyone does not know. So she came in, she did the ABG, which I had become accustomed to at that point. And she left. And when she came back into the room, she grabbed the rolling stool. She hadn't said anything yet, but she walked into the room and reached for the rolling stool. Now, again, as a chronic illness girly, the doctor coming in and sitting down, not a good sign. Doctors usually try and, say what they need to say and head out to the next patient. When they sit down, it's usually not good news. So she came in, she sat down. She said, Courtney, I am so sorry, but I am going to have to intubate you. And it was awful because I had already been intubated before. It was awful, very traumatic. But she was honest with me. And that's what I appreciate. There was no, sugarcoating or anything of that nature. She absolutely told me the truth. She said, Courtney, I am going to have to intubate you right now because I do not trust that the treatment will work fast enough for your body to get back to a place where it can function on its own. Deep breath. Okay, doc. Okay, I understand. She said, I'm gonna be with you, but you're gonna be out in a few minutes. I said, okay. We went through the process. I was on a ventilator for 4 days. Finally came off. Great. Went home and started looking online for groups for anything because I don't have any information. I don't know, I don't know anything. No one's telling me anything. No one knows. So I go online looking for groups. And the only thing I find are things like, um, here's what's in my duffel bag that I take to the hospital so that, I keep a potted plant, a fake plant that I can put in the window. And as much as that is useful for a lot of people and good, that is a good thing. What I didn't see a lot of was people actually telling the truth, people being honest. Hey, this sucks. And it's probably going to continue to suck for a while. But here's some things that I found that helped me. I didn't see it at all. So I had to do what I had to do. Come 2017, I had to figure it out, do my own research, look, search, find. I ended up being on plasma exchange as almost a Hail Mary. I had 2 tunnel catheters get infected. One sent me back to the ICU. And I currently have a AV fistula for outpatient plasma exchange. And eventually it stopped working. I was on rituximab and plasma exchange. Eventually it stopped working. I was having the worst body pain, trying to figure out how to have a life, have a full life, but also take care of myself and listen to my body. So I get online. I'm in pain. I don't know what this pain is, so you got to figure it out. I found 5 or 6 pages down in a Google search, this drug called Restigo. Brand new on the market. It had only been FDA approved for 8 or so months at that time. And I said, well, let's take a look. Well, this sounds useful. Because at this point, we're grasping at straws. There's nothing left here. And so we go ahead, I bring it to my doctors. My Dr. Hazariwala was my neurologist at Kaiser, in addition to Dr. Vita Kesner. She's a neuromuscular specialist at Emory Brain Health Center. So that was my dream team. So I took it to both the ladies and I said, hey, look what I found. Y'all want to take a look? See if this might be, something useful. And thanks to them, thanks to Emory, thanks to Dr. Kesner, I was able to start that medication and it has changed my life. It has absolutely changed my life. And as a result, not only has it changed my life, there have been, at that time, the medication required a special pump. No one in the Atlanta metro area had one, so I had to wait about 3 months for it to be ordered and sent to Emory. Since then, at least 4 more patients are on Restigo at Emory Clifton main campus. And every Emory clinic across the metro area has at least one of those pumps, so that anyone and everyone can have access and not have to wait 3 or 4 months, for this special pump. And I'm glad that I had that opportunity to impact other people around me. That was the whole point. Someone to be honest, someone to do what they could. Now, we all have a part to play. Next slide, please. I would not have been able to find that Restigo, really even survive up until this point, had it not been for the lab staff everywhere. With an invisible illness like mine, there are no outwardly indications. There's nothing to see. You can do a triage, blood pressure fine, heart rate fine. There's no indication outwardly. The only way is via blood work. The only way to definitively confirm is via blood work. And thankfully for me, I had Dr. Hazard-Walla, a doctor that really, really believed me when I said things. And when I told her that, hey, doc, the symptoms are on their way back, she went ahead and, did what I needed to do to help me out, even before the lab results came back. So I am grateful for that, that she believed me, and without necessarily having to wait for the lab work, I was able to get the care that I needed. But we still needed that lab work because Kaiser wanted proof. And so every single time, every 6 weeks, lab work. And I want to shed a light, because although we don't see the lab staff, we are you guys as patients too. A lot of times, most of the times, you guys are the first to know, before the doctors, before anyone's life has changed. You guys are the first to know. And I want you to know that as a patient who heavily relies on blood work, I appreciate the time and attention to detail and making sure you have everything correct, because the news you send up may change someone's life. And as you can see on the little graphic, there are several different things that people are diagnosed with before they get their diagnosis via blood work. So even in those things, the diagnosis isn't being treated. Yes, you may have the depression and the body pain and things, but there's a cause, and the only way for the cause is down to the blood work. Now, the next couple of slides are for, I just want to talk to each group of people. We have one for patient care providers, and again, that's where I was like, the doctors, the specialists, the nurses, the techs, the CNAs, janitorial staff, everybody. We are all their patients as well. And to the patient, the patient-facing caregivers, we as patients understand that no one knows everything. right? We're coming here for answers. Y'all aren't God. We get it. But there are a few things that are helpful for as a patient to hear, to help us be a little more at ease. Number one, obviously, listen, believe the patient. You may be the expert in the field, but that patient is an expert with their body. They live in it every day. So ask questions. Listen to the answers, because it may not be the answer you're looking for, but that answer could lead you to where you're trying to get. 2, be honest about what the patient may be facing going forward. I know y'all don't want to scare anybody, but people need the truth. That's the only way they can be prepared. Or even, not blindsided. Tell them the truth. It'll be hard for them to hear at first, but they will appreciate not being sugar-coated. Next, like I said before, we know y'all not God. If you don't know, that's okay. We know y'all don't know everything. That's okay. But I don't know. And you know what, Ms. Campbell, I don't know, but I'll do what I can to try and get you some answers. That second response goes a much longer way in building a patient relationship, in building patient trust with the individual care provider, but also with the system as a whole. And collaborate. Let me tell you, my favorite thing, and as y'all can imagine, I have a team of specialists. They're all women, by the way. My favorite thing is when my care providers leave me out of it. Y'all want to talk, this treatment versus this treatment, narrow it down and bring me a couple choices, like 1 or 2. Leave me out of it. I don't have a white coat. Y'all talking jargon. Y'all can talk to each other. Collaborate with it. It'll be easier. You'll get less frustrated because you guys talk all the same language. Collaborate with each other. Why not? They may know something you don't know. You may be able to teach somebody something that they take and change someone's life. Next slide, patients, caregivers, and families. So on this first side, we're going to go with the caregivers and families. Caregivers, families share the load. You can't carry this disease for them. I know it hurts to watch them go through things, but you cannot do it for them. So because they can't hand you this, you come in and take something else. You come in and take something else off their plate. They can't hand you this diagnosis. They have to carry it, but you can carry something else so that they don't have to carry quite as much. Know what's going on. The patient cannot be the only person with the information, right? Keep a list of medications in your wallet. Take a screenshot, keep it in your phone. But if for any reason your patient, if for any reason your patient isn't allowed, if for any reason the patient isn't able to communicate that, family's gonna have to step in, caregivers gonna have to step in. And lastly, we talked about my support team in the beginning. I wanted to highlight, shout out, give public appreciation to my support team. On one side, we have my parents there, Talene and Gerald Campbell. On the other side, that's my niece and my two nephews. Those kids absolutely have my heart, and they keep me moving. They keep me moving. And in the middle, those are my two sisters. One is a mental health nurse. The other works with our veterans with the VA hospital. And I could not imagine where I would be without them. My absolute built-in dream team. I just want to appreciate the people that have carried me up until this point. So thank you guys so much. Thank you guys. Thank you all, everyone here, for giving me this opportunity and listening to this. Next up, we have Michele Mitchell, and she's going to get into the story of closing the gap between pathology report and understanding. Thanks so much.
Wow, Courtney, tough act to follow. I'll do my best. Thank you for your powerful story. And today, what I would like to share with you, we're calling Behind the Slides. It's my story of closing the gap between pathology reports and true patient understanding. I want to talk about strengthening, if we could go back to thank you. I want to talk about strengthening the human side of laboratory medicine so clinicians, laboratorians, patients, and families can have clear, compassionate conversations about testing and results. And I, like Courtney, want to share this through a very personal lens, starting with my own story, because you have a right to understand your results. Next slide, please. So just as a way of introduction, my name is Michele Mitchell. I'm a breast cancer survivor and a national patient advocate. I serve on the ASCP Patient Champion Steering Committee, and I work with the Digital Pathology Association, a website called mypathologyreport.ca, and the American American Cancer Society Reach to Recovery Program. I live in Michigan, and so here locally, I'm involved with the Michigan Hospital Association, the Michigan Clinical Trials Consortium, and most recently, the Michigan Licensing and Regulation Care Continuum Organization. So my work spans both national conversations and local on-the-ground advocacy. But at every level, I'm committed to one thing, and that thing is to advance patient-centered care. And every one of those roles trace back to the one experience that I had. Next slide, please. This was the biggest battle of my life, breast cancer. And it hasn't been a single fight. It's been a marathon. And there have been 2 scares since original diagnosis in 2006. You know, cancer has taken a lot from me over the years, and I live with the thought of reoccurrence and with the lasting side effects of the years of medications I've been on. It's with this time frame, a marathon, not just a moment, that I want to share my story with you. Because behind every pathology report is a person who is living through the hardest chapter of their life. And I want you to hold that picture in your mind for everything I share next. Next slide, please. Why this conversation matters to me. It was a decade after my diagnosis that my pathologist, Dr. Jeffrey Myers at Michigan Medicine, sat down with me and walked me through a digital image of my tumor slides. You know, seeing the actual cells explained in plain language with compassion gave me something my written report never could: clarity. control, and the feeling that I'm a person, not just a specimen. That moment is why I do this work. Next slide, please. So many of you may not be aware of a rule that went into effect, and that is called the 21st Century Cures Act. Reports are available now in near real time. Patients now have access to their pathology reports, lab results, visit notes on their portal. And that's a profound shift. It means the conversation about how we communicate results can't wait. Next slide, please. This was a revealing study. By the way, all the references will be shared with you. It was a Harvard Medical School study that just came out in June of 2025. And it found that half of Americans feel there's a real lack of compassion in healthcare. Half. That's a gap we're here to close. Next slide, please. The research is clear. Patients need answers. In this study, 95.3% of patients wanted immediate access to their results, even if it meant seeing them before the provider, and even if the results were abnormal. But the study showed that within 6 hours of viewing those results, worry sets in. And 57% of those go looking for answers similar to what Courtney did on their own. Patients aren't waiting for the healthcare system anymore. They're already looking. Next slide, please. So where do patients turn when they're looking on their own? Well, increasingly, it is AI. That tells us there's an opening and a responsibility for pathologists to be that trusted voice instead. The good news is there's training available, and it can be taken by anyone, like the resources at Choose Your Path from Vital Talk, and that these training sessions help clinicians step into that role with confidence. And there's a brand new study out on exactly how AI delivers messages through large language models in pathology reports. They compared the AI version, with the pathologist. This particular study was just published in the American Journal of Clinical Pathology. It comes from Dr. Jason Wasserman and his colleagues, that same team behind the mypathologyreport.ca website that I mentioned earlier. And the ASCP actually has partnered with Dr. Wasserman, jointly developing materials and co-authoring research together. I'll add that this site is personal to me, too. I've been one of the patient advocates vetting its content for patient-centeredness since its inception, alongside other advocates who care just as much about getting it right. Well, back to the study. The study found that AI-generated explanations of pathology reports held up remarkably well against explanations written by pathologists. Strong on advocacy, strong on clarity, but empathy was the lowest score of all for the AI-generated pathology reports. So, do we really want AI to replace that human contact? I don't think so. Remember, pathology is human work. Let's talk about another alternative. Next slide, please. What should patients know about pathology and lab reports? Well, pathology and laboratory medicine sit at the core of every diagnosis. Patients have a right to see these reports immediately, and understanding that what that report means is empowering. It's transformative, and it was for me. It helps patients make informed decisions, and it tells them whether their treatment is working. Next slide, please. There was a landmark study that I found that it's entitled Clinicians Are from Mars and Pathologists Are from Venus. And what it found was that clinicians and pathologists often speak different clinical languages, similar to what Courtney had mentioned, about the same report, though. And that roughly 30% of the time, clinicians remarkably misunderstand the pathology report for their own patient. Now, if the treating team is uncertain, the patient will feel it first. Next slide, please. There have been several studies on this, and what we found is that patients want to meet with their pathologists. Clinicians want them to meet with their pathologist, the patient's pathologist, and pathologists want it too. 3 independent studies, 3 different groups, 1 consistent answer. 86% of patients support meeting with their pathologist to review their results. 83% of pathologists want to meet with their patients, and 85% of clinicians want to see that direct engagement happen. The appetite is there on every side of the table. One of those studies came from here at Michigan Medicine. It was a study of interests and motivations in cancer patients. They surveyed 100 cancer patients and found 85% were interested in meeting with their pathologist to diagnose them. And when patients explained why, 3 themes kept coming up: empowerment, demystifying the process, and wanting a deeper understanding of their disease. In their own words, quote, "Knowledge is power," one patient wrote. Another said meeting with a pathologist would help them understand exactly where and what my cancer was. That's not an abstraction. That's what real patients told researchers they wanted. And it wasn't just 1 or 2 comments. Patients described wanting to see what happens, quote, behind the scenes, wanting a more personal connection instead of hearing everything secondhand, and wanting plain answers to real questions, like what their staging actually meant, or why their tumor was graded differently at 2 different institutions. One patient told researchers, quote, "I still don't know what all the wording on my path says. Would be nice to be able to have someone explain it." Over and over, it came across to the same thing. Patients simply want to know what is going on inside their own body. Next slide, please. So how do you do it this well? Introduce yourself and your role. Ask open-ended questions. Gauge the emotional landscape and deliver information in small chunks, pausing to checking understanding. And fire a warning shot before difficult news, like, you could say something like, "This isn't what we had hoped for." Remember, listening is communicating. I mentioned earlier that about the Vital Talk conversation. And their training backs it up with a study. The training significantly boosted participants' confidence as well, with meaningful improvement across every skill measured. There are a few pitfalls I'd like to mention. Don't overwhelm a distressed patient with more detail, and don't dodge emotions by hiding the facts. Both leave patients feeling unheard. When there aren't any more questions, pair honesty with compassion. "I know this is difficult news, and I wish we had more options to explore together. We're here to support you in decisions." One more study that I'd like to mention makes the case for the Serious Illness Care Program. It was a trial, and it found that training clinicians in these types of conversations led to early, better documented conversations about patient goals. And afterwards, families described a greater sense of peace and care that better matched that patient's what they actually wanted. Next slide, please. And there's proven techniques for this. There's the ask, tell, ask approach, which I think you're all familiar with. There's another one called NURSE. It's a framework for responding to emotion. NURSE breaks down into 5 real usable moves. Name the emotion. It sounds like you're feeling really overwhelmed. Understand why they feel that way without necessarily agreeing with their conclusion. Respect their effort and resilience and support them. I'm going to be right here with you. And explore with an open question. What worries you most about the diagnosis? Used well, it reduces patient anxiety and shifts the focus from clinical tasks to real patient-centered care. And these skills stick best with authentic practice. That is, practicing makes you better at this type of conversation. Cases that mirror pathologists actually meeting face-to-face is what works best. Next slide, please. So how do you make these pathology appointments and clinic visits happen without adding burden? 2 keys. First, securing leadership support. Capitalize on your pathology department's proven track record for quality and professionalism and position this as a strategic initiative aligned with the goals every C-suite already cares about. Patient engagement, satisfaction, and transparency. That's a compelling value proposition for the executive endorsement. And second, use the infrastructure you already have. Pathologists, although working behind the scenes on their microscopes, they're MDs. You already have the billing capacity and capability. CPT codes like 99203, which is your normal office visit code, already support patient-facing consultations. And you can integrate this right into your existing schedule and documentation workflow. This requires minimal operational change. Next slide, please. You can also expand access without expanding staff time. Virtual visits, like we did during COVID. Use a navigator role potentially in the pathology department. What about messaging pools through the portal? All increase your reach without adding hours to anyone's day. And finally, pilot before you scale up. Test one communication change on one single pathway first. A scalable approach reduces the risk and gives you a model you can expand system-wide with confidence. Next slide, please. Well, that's why we developed a playbook with the ASCP. And I am so proud to have worked on these modules myself. I was the only patient on the working group, and the ASCP wove my story and other patients' stories throughout all 7 modules to bring real lived experience into the content. It covers every aspect of building your own pathology clinic program at your facility, from pitching it to the C-suite, to operationalizing it, to keeping it sustainable in the long run. And it's full of pearls of wisdom from pathologists around the country with real-world examples of how this actually has been done. Because pathology and laboratory work is human work. Next slide, please. This is important. Healthcare professionals need to reach patients across cultural backgrounds to help reduce systemic disparities. This has to work for everyone. Make it concrete with images. Walking through a digital slide turns an abstract term into something a patient can see and ask about, especially if it's their own cancer they're looking at. Use plain language. And always bring a professional interpreter. Don't rely on family members. They're too emotionally involved in the issue. This matters most in underserved and marginalized population, where the stakes of miscommunication are highest. This type of interaction points to something everyone in healthcare needs to recognize. Effective communication starts with empathy and cultural awareness. Pathologists have to adopt how they share information, not just so patients get accurate results, but so they feel understood, respected, and supported in their decisions. That means understanding a patient's perspective, engaging in open dialogue, and offering culturally sensitive education so decisions are made together, not handed down, which is essential in closing disparities rooted in different cultures. Next slide, please. Just as important is measuring patients' benefits once the pathology clinic is in place. The next step in improving that it works, and the good news is that it doesn't require a complicated evaluation process. It's a simple pre-post cycle. Set a baseline, implement the change, then remeasure at regular intervals. From the patient perspective, you should track whether the explanation was clear and helpful, whether patients would recommend the service to others, and whether they feel confident continuing with their treatment plan, along with patient satisfaction, was additional testing required, and were there any diagnostic errors? And the benefits to patients are specific. Better diagnostic comprehension, reduced decisional conflict, enhanced trust, real commitment to the treatment plan. And overall, it strengthens the whole concept of patient-centered, multidisciplinary care that Courtney had mentioned, her dream team. Next slide, please. Well, the benefits extend just as clearly to the providers who do this work and the health system. Pathology clinics open a new pathway for diagnostic communication. They improve clinician efficiency and make the pathologist's role far more visible, supporting every specialty that depends on that report to guide treatment. Hospitals gain a real reputational advantage too, more value in the eyes of credentialed bodies, and reduced burnout for staff, since pathologists get to see the direct impact of their work. On the tracking side, here's some ideas. Referral to visit time. How long it took you to turn around that message. Percentage of summaries sent within 1 business day. Again, patient satisfaction. Were there any diagnostic errors identified? Were there any additional testing? And referring physician efficiency. Same story. So many benefits, no downside. Patients benefit, providers benefit, health systems benefit. Next slide, please. So what can you do this week? For pathologists and laboratory teams, there are a few simple steps. Add a plain language check into a workflow you already have. For the pathology report, there's always the addendum. You can add some patient-friendly terminology there. You can add your contact information. Document patient encounters so the whole care team shares one message. If you do meet with a patient, leave a visit note in the portal that can be shared and reviewed by patients later on. It's also important to set the right expectations. Patients aren't looking to assign fault, as Courtney mentioned. They're looking for understanding. And when you can, bring a resident or a fellow along into the conversation so you can begin to build the next generation of patient-centered pathologists and laboratory professionals. Next slide, please. For patients and families listening today, you have a role too. Before your appointment, review your report and jot down any words or phrases you don't understand. Then simply say, I'd like to better understand my pathology. If you're ready to go to the next step, ask your care team, is there a clinic where I can meet with a pathologist to review my slides? That question opens the door to a real conversation, not confrontation, a partnership. You can also ask your doctor whether they can refer you to the right department within the health system. The goal isn't to challenge anyone. It's to become a more informed partner in your own care. Next slide, please. I would love for you to connect with me. You can find me on LinkedIn. I have my own YouTube station. I'm my own producer, so just be careful. I don't have any funding for this. I'm doing it on my own. It's called Empowering Patient Engagement. And you can reach out to me on Instagram or by email. I'll leave these up on the screen for just a moment if you want to copy down some of those links. And the next slide, please. These are those references that I talked about, which I'm sure will be shared after for all the studies that I mentioned in my presentation. I want to leave you with these words. I hold no formal power, but I do have a voice, and I will keep using it until every patient sees and every pathologist remembers the life behind the slide. Thank you so much for the opportunity to share my thoughts with you today. And now it's my great pleasure to turn it over to Dr. Penn.
Great, thank you. Good to see you all. Great presentations so far. I hope I can add some additional insight to the great things you all have shared so far, and great insight, and appreciate all you've shared so far. If you want to go to the next slide, please. This is a photo of my family and myself at a ski resort in Illinois. Yes, you can ski in Illinois, if you can believe it. It's a very short but fun season along the Mississippi River there. I'm a former high school math teacher, and I have a doctorate in qualitative, quantitative, and psychometric methods, and a public health master's degree from North Dakota State University. Currently, I'm Director of Assessment and Continuous Improvement at the University of Iowa College of Education here in Iowa City. And in my spare time, I of course do some winter sports. I also play trombone. I enjoy traveling and bicycling as much as I can. I'm going to go to the next slide. I can also show you two other members of our family. We've got a he's still a puppy, but he's huge. On the left there, a giant golden retriever dog and a kind of mixed breed dog. They're both kind of big babies. They usually sit in my office with me when I'm on meetings and things. They're off doing something else right now. And then that's our family at on vacation earlier this summer. So today I'm going to tell you more about Samantha's journey. She was born in 2009 in Oklahoma. There's a picture of her on the swing set at a playground near where we lived. She had a pretty typical first year of life. All those new parents, what do we have to compare it to? Not knowing what's typical, what's normal, as not having had our own babies before. At the first year checkup, the pediatrician was a little concerned with what they called failure to thrive, and we're like, what does that mean? Like, she seems like she's doing okay to us. She's small, but like that term doesn't really make a whole lot of sense to us. And so the pediatrician had us do some what she considered routine blood work, and the numbers, as they always say, the numbers, right? The numbers looked fine except for her thyroid, which was not a huge surprise because both my wife and I's families have had thyroid challenges in the past. And so the pediatrician said, well, let's put her on some Synthroid. And the next few months after that, things seemed to be making progress. She was growing more, getting some more hair, making more progress toward those milestones. Later that fall, she got a colder infection. It seemed to hang around for a little too long. And so went back to the pediatrician, and the pediatrician was, again, somewhat concerned. And so she had us do some additional blood work. And with that new blood work, the pathologist, I never forget the report, but the pathologist wrote back and said the sample was unusual. Like, and the results were unusual and the sample was unusual. And like we're like, what does that mean? What does unusual mean? Unusual good? Unusual bad? Like unusual like what it's just not I don't know what we had no idea what to make from that terminology of unusual. And so we got sent off to some specialists and they did some additional tests and things and eventually her cold kind of cleared up and the specialists all kind of said, well, it looks like she's doing better, her cold is gone, and they seemed satisfied, and that was that. So off we went back to our lives. A few months after that, again, this time she got really, really sick and wasn't eating, kind of laying around, really had changed her behavior and much more concerned this time. And so the pediatrician admitted us to a children's hospital in Tulsa for some more intensive care. At the Children's Hospital in Tulsa, we had a couple of specialists, a hematologist, an infectious disease doctor, the internal medicine doctor. They all had long arguments with each other about what was going on with Samantha. Not in front of us, but we heard about them from other members of the care team that sometimes these arguments between these three physicians were quite vicious and sometimes ended up in screaming matches, apparently, is what we heard secondhand. Now, I'm glad they didn't do that in front of us, but on the other hand, maybe not the most professional of behaviors to be engaging in with your colleagues. And I'm not sure what all of the context is there. And at the time, there was, based on the rules of the hospital, there was no immunologist who had permissions to visit patients in the hospital. So I'll talk about this more in a little bit, but it's one of those system issues that really prevents the best care and the best access to patients getting what they need. So the only specialists we had were these that had the rights to the hospital, and so this team of these three physicians, they all kind of had this tunnel vision, and they often were like thinking only from their particular specialty training. Like the hematologist wanted to do chemotherapy, the infectious disease doctor wanted to treat the infections, the hospitalist wanted to do these other things, and it was all based on what their particular training was, and none of them could really see the more broad picture of what was going on. So after a couple of weeks in Tulsa, we were transferred to Cincinnati Children's Hospital for treatment for an immune deficiency, or maybe something called HLH. They weren't really sure in Tulsa what exactly was going on, but they knew at least after 2 weeks that they didn't know enough of what was going on and sent us off to a place where perhaps we could get more of those answers. So once in Cincinnati, I drove with my mom, and Samantha, my wife, flew on a fixed-wing aircraft from Tulsa to Cincinnati, whose bill, by the way, you need to see to really believe how much that cost the insurance company. But it became much more clear in Cincinnati what was going on. The correct tests were finally ordered. The correct interpretation was finally coming clear. And she was diagnosed with a leaky version of severe combined immune deficiency, which came with a 12-month treatment plan if her multiple infections could be treated prior to getting to the bone marrow transplant process. So it was a very lengthy and very difficult and sad diagnosis to hear at that point, knowing that the journey through those infections would be very difficult to get to the point of where the treatment would be possible. So even with some compassionate use drugs and other things that Cincinnati was able to offer, she wasn't able to fend off those multiple infections, and unfortunately, she died at 20 months old. So a couple of things from that experience I wanted to share about insights from our many weeks in the hospital and our long journey with the care team, and looking at many, many, many lab and pathology reports on various things. Go on to the next slide here. One of the things that I think is really important to highlight, and I heard it from our other presenters today too, is that the caring people really made a big difference in our journey, especially in what was an extremely challenging, difficult situation. And there were many people throughout the journey, from those that cleaned the room to those that worked with the insurance company to those that we interacted with along the way to friends of friends of friends who we were connected with throughout the experience. This is a picture of the Ronald McDonald House in Cincinnati. It's paid for by donors and volunteers, and it's there to help be a home away from home for those that are undergoing such long care and treatment journeys. And just the notion that people would care enough to produce and create facilities for families to be there at one of the most difficult parts of their lives is really a meaningful and important thing to us. And we even had, in Cincinnati, we had caring people who helped us fill out the Social Security disability paperwork, which is extremely complex and confusing paperwork. We sat down in a room with a group of other parents, and went through the forms, and the specialist told us how to fill these things out so we could get it all organized and made for and set to move forward appropriately. And just again and again, we came across people who were deeply caring, from the respiratory therapist. This is a person also, I'll never forget this person either, who was, pumping her breathing bag while she was getting a CT scan, even knowing that he was getting doses of radiation that maybe would not be great for him in the long term. I never forget how dedicated he was to her care. And also our ICU doctor being truly concerned and crying with us when, things weren't going well, and knowing that, that the things weren't progressing the way we wanted. And I know as those of you who work in healthcare, that kind of caring and that kind of investment in your patients is difficult to do on a day-to-day basis. And you can't invest maybe that same energy in every patient every day, especially when many of the patients have unhappy endings. But knowing it does make a difference, whether it's the person who's cleaning the sheets, changing the room over, telling us that they're thinking of us and keeping us in their prayers, or if it's somebody in the hallway or others throughout the whole experience that make it a little bit easier to navigate through a difficult circumstance. Now, with that caring, I would also say the other thing, it's also important not just to show that, but you can be explicit about it as well. You can tell somebody, we care about what happens to you. I'm following your journey, even though I'm on vacation next week or whatever it might be. I'm keeping track and following what's happening with you and your family because we care about you. So I think being explicit about it also is important too. So with that said, the importance of caring, we can move on to the next slide here. It was often within a system that was sometimes incoherent and dysfunctional, especially to parents and to families. So I think I mentioned this before, but doctors arguing with each other behind the scenes, and I'm glad they didn't maybe have these vicious, drag down fights and arguments in front of us as a family, but they all had this kind of tunnel vision, and this was a systemic issue that has to do with the way they're trained and the way that they're taught to look at problems. Everything they saw from their particular specialty view, and it wasn't none of the specialties that we had access to initially were specialties that really addressed Samantha's condition. So that was a difficult and challenging thing to figure out, like the doctors arguing with each other and not knowing that, like wanting our feedback or input into what we should do. And like, I mean, we don't know. We're not the specialists trained in these things. We see the same lab reports you all are seeing, but we don't know many of these conditions that you're tossing around as potential candidates for what you might have. Never heard of any of them. So we don't have any more insight than you all do. And so having that kind of uncertainty with the care team was very difficult for the family to know, like, what next steps should we take, what's happening with our child, what's going on that we should be paying attention to. There were also these arbitrary rules that seemed to be didn't seem to make sense to us in the experience. So the Tulsa hospital, for example, having what seemed to be arbitrary rules about not allowing immunologists to come into the hospital to take a look at it, because several of the members of the care team said, oh, we really should have an immunologist do a consult on the patient. But then they said, oh, they looked at records. Oh, there's nobody who has rights to come into the hospital. There's immunologists in town, in the community, but obviously she can't leave the hospital the way she was to go see them, and they couldn't come into the hospital. So it was like, this seems like a very arbitrary rule. I'm sure there are good reasons for having some of these privileges and rights processes, but there should be exceptions too when there's a clear and immediate need for an additional expertise to be brought into a case. So some of those kinds of seemingly arbitrary and unclear policies and things certainly got in the way of making decisions and doing things that were in the best interest of Sam's health. There's procedures and other things that also seem to elevate in the family's view the convenience of the hospital or the convenience of the staff, perhaps, over the needs of the patient and the family. So one of those that comes to mind was they wanted to do rounding with the patients. So the care teams would make their way around the floor and meet all of the families and make the plan for the day, starting at about 7:30 in the morning. So if you work backwards from that, they wanted to have all of the lab reports done prior to that. So that meant they would often come about 5 a.m. to collect the labs from the patients, usually blood draws or other things from the patients. And so, it's like the middle of the night, at least in my opinion, at 5 a.m. And you get the knock on the door. It's the nurse and the phlebotomist and somebody else coming in. We got to take these labs so they can be ready for the rounding later this morning. And you're like, I just fell asleep. I mean, there's all the noise in the room. There's people coming in and out. It's people walking up and down the hallway, and we finally get to sleep for a little bit, and now they're coming in to knock on the door, and it's time to start the next day again. And it's like I just had half an hour of sleeping, and now here you are, wanting to move this forward quickly because you have a very tight schedule for the care team. You want them to get the rounding done first so they can move on to their next activities, so they can move on. I understand all of that, but from the patient's view, it's like this is for the convenience and for the efficiency and for the value to the hospital, not for what's best for the patients. Because if we're here to heal and rest, we need time to actually do that, not be woken up in the like what feels like the middle of the night to have another thing done. The insurance company was another kind of challenging thing. We were very fortunate to have very good insurance, but it was still like unnerving to have them call and say, "How was your fixed wing flight?" Or have them call and say, like, "This is the bone marrow transplant team. We're going to coordinate how we pay for all of these things, how we are going to figure out how we make this work with your family and as the payers and the hospital." So it's this kind of another level of intermediary between the care team making decisions and us making decisions as a family. And then there's the kind of this third group with the checkbook that kind of decides what they will or won't pay for and what will or won't be approved. And so it's kind of another level of negotiation and discussion. And we even had really good insurance, so it wasn't they weren't holding us up, but it was still like another level of stress and confusion and like trying to figure out, like, when the bill would come, we'd be like, "Here's all these people on this bill. I don't know, like 6 or 7 of these names. Did we see these people? Who are these people? Are we paying for some of this? Like, what's going on?" And usually it was, in the middle of stress, you're like, you can't spend that time going through and saying like, "Oh, well, we never saw Dr. Johnson. We're not paying that part of the bill." Like, you just kind of have to put it in a folder and be like, "Well, that's just another thing that'll happen when it happens, and off it goes." So that was another challenging part of the experience, was just having this kind of third party being involved in all of these processes. Another thing that happened was there was a lot of assumptions about what families should know or understand about how things work in the hospital, about what the care the hospital would provide, and so on. A lot of this we had to like figure out on our own. Like Courtney was saying, there's a lot of just like poking around on the web. We're trying to like ask other parents, other families, like, what is going on with this thing that they're doing that everyone seems to assume they know what's going on. Like, for an example, was we weren't allowed to eat meals in our room with our daughter. Like other hospitals, like they brought in food for us, or we could bring in stuff and eat it in the room. At Cincinnati, they were like, "No, no, 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 you have to eat somewhere else." We're like, and they just kind of assumed we knew that. Like, well, no, that's everywhere else we've been has allowed us to eat in the room. Like, we'll follow your rules or whatever, but it just seems like, don't assume that we know what they are because we live in a very different context than other places we've been, and it was very difficult to like make sense of all of these things that they did that was different than other places we've been. Another example was she had high fevers as being a immune deficient. The infections would get very ramped up. Other places we'd been, she'd had Tylenol or aspirin or other things to kind of bring the fever down so she would be more comfortable. And Cincinnati didn't do that at all. They just kind of assumed we knew that was their practice. They're like, we don't do Tylenol because it can make the infections worse, and immune compromised patients, it can cause other problems. So, and like they kind of assumed we knew that, but it was never really explicitly talked through with us. There was the staff scheduling was another example of a kind of a confusing thing. That, as you know, most work on kind of 12-hour shift schedules. And so as staff rotated off, like every 12 hours, that meant we had to kind of re-explain all of Sam's preferences, how to communicate with her, here's what she likes, here's what she doesn't like, here's what she likes to eat, here's what she won't eat, here's how you might get her to do this. She hated the blood pressure thing. Here's how you get her to do the blood pressure thing in a way that she'll put up with. Every 12 hours, like over and over and over again. Like, now we got to start a new relationship with a new nurse or a new, who this next person is coming in. And just kind of a frustrating, dysfunctional thing to feel like we were just starting to get a relationship with this person, and then now they're off the floor for 2 weeks and we'll never see them again. Like, some of that kind of systematic rotation and how the staffing was set, but just didn't seem to make any sense for us in a patient-centered perspective. And finally, it was difficult to maintain kind of family normalcy. We were in the hospital for, I think, 8 or 9 weeks. And that covered 2 birthdays, Valentine's days, other things that we would do for celebrations and activities that we would have done as a family. But that sense of normalcy is gone, and trying to find a way to still hold on to some of those things and capture some of those things can help reduce stress and improve mental health. But it's often difficult to do that in a way that was fit in with the structure and systems of what the hospital had going on. So let's move on to the next slide. So I think you all are maybe familiar with some of the systematic challenges and problems. So empowerment is another thing that we've thought a lot about and talked about in our experience, and of course has come up in the webinar today. So I think some things to think about that we pondered as the families was, what does it mean to families? What does empowerment mean? What does it mean when we're balancing this child's right to be healthy? Can we make decisions that might not be in the best interest of the child? What does that look like? We often wondered about who is able to make decisions, and even what are the range of decisions we're able to make. And will somebody pay for it? Like, do we have to call the insurance company and say, like, here's what we want to do. Are you going to pay for this? At one point when we were in Tulsa, one of our care team came to us and said, they're thinking of transferring you to Cincinnati. If you request a transfer, it might go forward more quickly. Like, and they were trying to empower us to make decisions. And we're like, what? Why would we request a transfer? Like, what is going on? Like, why should we request a transfer? Like, nobody's talking to us about this possible transfer. Why would we want one? Like, we're totally lost here. And if we were to request a transfer, like, who do we submit a request to? Like, the insurance company? Do we go to the physicians? Is there somebody at the hospital we email? Like, what do you mean? Request it from whom? Or do we just go? Like, what do you mean? And if a transfer to another place is needed, why are you waiting for us to be the ones to request it? Like, I don't get that either. Like, what are you talking about? Like, it was one of those examples where, like, I think they felt like they were empowering us, but it was very confusing. We were completely lost in that, and it was also like made no sense with what else had been going on. Let's go on to the next slide here. So other things with empowerment, it's not empowerment if the physician or the care provider like rolls their eyes, either like literally or subconsciously, when they're going through and doing the thing that you asked them to do, right? When we had our son a few years later, we knew that he was at risk for having the same condition that Sam had, having an immune deficiency. And so my wife gave birth to him, and then in the couple of days before we got the results back from his immune deficiency testing to see whether or not he had the same condition, we had asked nurses to put on a mask when they came into the room, just to make sure that if they had something, that it wasn't going to be passed on to him. And many of them did so reluctantly. When they came into the room, oh, I got to put a mask on my face, and they kind of roll their eyes, or they would forget it, and we'd have to remind them, could you put a mask on? He's at risk for having an immune deficiency. And that's not empowerment if you like roll your eyes and reluctantly do the thing that the family has decided to do. So he fortunately didn't have an immune deficiency, totally healthy. But it still is one of those things that's like, it's not empowering if the care team is like, oh, we got to carry through on this thing that the family asked for, even though we think it's a dumb idea. And empowerment comes with risk. There's always risk to that. And in many situations, like with Sam's, there were no good choices for Sam. Like all the choices were bad. And so empowerment, yes, but also the family was still struggling to decide what to do because there were no choices that were like clearly a better choice among those that we had. The last thing I'll say about empowerment is that I'm a family advocate, but also a children's advocate. And just to remind you that children have a right to be healthy. And while families are the center of the child's care team, and children need their family to help them grow and heal and develop, not all parents make decisions that are in the best interest of the child. And I'm not a lawyer, and I'm not a legal expert, and your clinic or hospital may have rules and things, and a legal counsel may need to talk with as well. But just remember that to know your values and to know when empowerment is a good option and when there might be need to be others who are not the parents perhaps advocating for the child's health and their best interests. Okay, so finally, let me talk about one last thing, and that's the communication chasm. I love this picture because I often felt like we were on one side of the chasm and the care team was on the other side of the chasm. Like, we could look across the chasm, like we could see them over there, and like we knew like they're trying to get our attention, tell us something, but it was like so far away, like it often didn't make it across the canyon. Like, we know you're over there. We know you're trying to tell us something important. What is it? Like, we don't get it. So like there's this big gap. So if you want to go on to the next slide, one of the major frustrations I think was with our what we call some weasel words, like words that would show up in a pathology report that we're like, we just want answers. We don't want like more wandering around or hedging your bets. You can go one more slide. Words like we saw this one in one of the reports, unusual. This sample is unusual. Like, I mean, what does that mean? Like, we don't we don't look at samples all day. What does that mean? Or things like this may indicate. I may indicate like that we're coming to you for answers, right? Like, well, I don't know what you tell us what it indicates. You might consider following up. Like, how am I going to? What do you mean consider? Should we follow up? Like, or should we not? Like, I'm considering it. I don't know what that means. Um, these results are suggestive of. Yeah, suggestive. I mean, it's okay, but settle on something out of normal range, inconclusive, or clinically correlated with these results, or cannot rule out, right? So these are things that are difficult and challenging when families are reading reports to make sense of like it's not you're not advancing us toward an answer by kind of weaseling through these things. And they may be medically correct, and they may be medically accurate, and they may be legally required to be in these reports. But families, and our family in particular, found them very frustrating and not helpful in moving forward toward getting some kind of ultimate diagnosis. So I'm sure there's good reasons for these, but the more clear and the more honest you can be is really helpful. Going to the next slide. Another language issue is trying to understand that common words have very different meanings when it comes to a medical system. So, negative is good, positive is bad. There's all these acronyms that get thrown around that everybody else seems to know that you're like, I don't know what those letters mean. Is that a word or is that an acronym? Is that a hospital department? Like, what is that? And even the measurement units are very difficult to make sense of. So we'd get these reports back and it'd say like, you have 58 IU per ml. Like, what is that? I mean, I know what 1 ml is, like 1 cubic centimeter of blood, and that lower is probably better than higher, but I don't have any idea if like 30,000 IUs per ml is better than 50 IUs per ml. Like, I mean, that's you look at that and I'm like, I have no idea. What is that? Like, it's hard to make sense of that. So it's a communication chasm that really is difficult when you're looking at these reports. You're like, I mean, yellow, green, red is fine, but that makes not a lot of sense to me. The clinical language was often glossed over, and so often when we're reading reports, we would kind of look for cues. And I think a lot of families do this, cues either between the lines or in how the results are presented by our care team that indicate like, are they happy? Are they sad? Are they indicating concern? Are they confused? Like, is there some reading between the line that we're doing, trying to see because some of these things don't make sense in these reports? Is it better? Is it worse? Like, just bottom line, like, is it getting us closer to an answer? Like, are we at least a step closer? And this just overall, there's this sense that the physicians in these reports were trying to tell us something important, but they were struggling to kind of get through for some reason. Let me go on to the next slide here. Another communication challenge. Sometimes we had this happen where we would be in the room and somebody would show up at the room. Hey, I'm here to do procedure XYZ. And we're like, this is the first I've heard about this. What are you talking about? What is this procedure? I'm here to get blood. For what? We need another sample. The doctors want to rerun this thing. Like, for who said that? Like, and so it's impossible to have the same person in the room 24/7, and they may have talked about it with somebody else. They may have not. So it's very much a communication chasm when they show up and they're like, I have to do this thing right away. I've never heard of this before. And also the sense of whose job is it to kind of reveal bad news? We had one doctor come in one time and said, has anyone said anything to you about liver failure? No. I mean, you did now, right? I mean, that's like, did they draw straws back there to see who gets the chance to deliver the bad news? Like, what's going on? Like, someone should have a regular way to make communication about what's going on a regular basis. So we had this impression often that everybody else knew more about what was going on with our child than we did, and they weren't telling us things because they either didn't know how or couldn't or didn't want to. So I know we're going to run out of time here, but a couple more things I want to share. Let's move on to the next slide. Another challenge in looking at the pathology reports and reading the reports is just understanding the context of the results. So this is a picture of some milk cartons, and you can see they have a expiration date of February 26, 2026. And the question is, like, this is a very simple question. You see the expiration date printed on a bottle of milk. It's February 27th. Are you going to drink it still? It's one day later. I probably would. My wife wouldn't. But what about a year later? Would you drink it a year past the expiration date? Like, probably not. I don't think anybody would. You probably open it, it would probably be just one, like, big solid chunk of milk. You also see there's a time printed on there, right? 1943. Would you drink it 1 minute past the expiration date? Like, is this like the exact date of expiration, or is it like kind of, here's a range. Within a week or two of this, you're probably okay. Go ahead and drink that. It's the same kind of challenge when you're looking at medical lab reports. Go on to the next slide here. You get these results back, and you're like, oh, 113.568. That looks like really precise. Like 113.578 would be better. But knowing that like a minute later you take a different sample from the patient, maybe you get 115, or you test on a different machine, maybe you get 112. So it's not really clear to make sense of whether change was random, whether it was a meaningful change. We know up or down, but like how much up or how much down is like good or bad? And what does it mean for the child in front of me today? Is she improving? Is it, is this kind of milk example? Is it like you got to hit to 120, otherwise everything's bad? Or is it like, 117 to 130 is probably good? There's kind of a range of responses you could have there. And looking at that was just really difficult for us to make sense of what's random, what's actually changing. Is it a machine difference, just a time of the day difference? Like what's going on that we have to make decisions about for the child in front of me, and knowing that there's often this what appears to be an illusion of precision in how the results are sometimes presented. So one more slide, please. So thank you all for listening and hearing the story. Just to kind of summarize a couple of my top points. Caring people at all levels made a big difference, and so never underestimate what it means when you share that with a patient. Dysfunctional systems and processes often got in the way of empowerment for families. We often wanted to do the best thing for our child, but it was often unclear what choices we had or what choices would be truly best. And often there were no good choices available. When it came to reports and other information from physicians, there's a lot of reading between the lines because we don't always understand the jargon and the details of the report. So there's a lot of like trying to get a sense of from body language and other things like, is this good or bad? Are things heading in the right direction? And there's also this big sense that, the care team was kind of on the other side of this chasm. Like they wanted to tell us stuff. They knew things that were going on, but they couldn't quite get it across that large gap for some reason. I know there are a lot of guides and steps and good resources to use in communicating with the families and how to break bad news. Those skills are really important, and I totally encourage you to go and pursue developing skills in those areas. But there's nothing better than a strong relationship with the family and truly listening to them and getting to know their journey on a personal level. Every family is different. Every journey is different. And building that relationship, I think, is the best way to support long-term success. So thank you all. I'm going to turn this back over to our moderator, Michele. Thank you.
Thank you, Dr. Penn. First of all, thank you to all three panelists, Courtney, Michele, Dr. Penn. It was really powerful to hear your stories and experiences. I think I speak for all of us in the audience that we feel privileged to hear how you've used those deeply personal experiences and extended them as a vehicle to positively impact others. And you certainly positively impacted all of us today through the information you shared. So thank you. What I heard in each of your portions in today's webinar was really about how impactful the actions of just a single person or multiple people, including members of the laboratory pathology community and teams, were in your journeys. So that was really, again, very powerful messages to hear. We do recognize that we did not have time for Q&A, so we'll review any questions that were submitted after the session and include relevant responses for you all afterwards when we share today's material. Next slide, please. As we wrap up, we'd like to introduce today's highlighted resource, the Negotiation and Advocacy Toolbox. This toolbox provides over 100 templates, tools, presentations, guides, and other vetted resources that were developed or recommended by members like you all, ASCP members, to help laboratory professionals demonstrate the value of their lab to the C-suite, hospital administration, and others. I'd also like to highlight the second QR code, which is the Patient and Family Guide to Lab Testing. I saw that dropped in the chat as well. This is a prime example of one such resource that came out of this toolbox. It has a guide of frequently asked questions, and this was co-developed by myself. I'm a laboratory professional, and a pathologist, Dr. Kamran Mirza. And it includes questions that patients and their families may have about the laboratory and the results they receive. I thought about it when Dr. Penn was speaking, and if a result's slightly out of the normal range, but your clinician doesn't seem concerned about it. Well, as a patient or a patient's family member, why aren't you concerned about it? What does that mean? Different types of, questions and topics like that. And so this tool is valuable in a multitude of settings to provide this clear, easy to follow explanation for these topics and education about how the lab impacts their care and how to broach these types of topics that may be unfamiliar to patients. Next slide, please. On behalf of the ASCP, we'd like to extend our thank you again to the panelists and all of you for attending today's webinar in the Building Bridges series that we're hosting and continuing into 2026. We do look forward to seeing all of you at our next webinar, which is titled Bridging the Generational Divide. That's next month on August 19th, same time, 11 a.m. to 12:30 p.m. Central. Last slide, please. Finally, a few more resources. We encourage you to visit supportcdc1lab.org, where you'll find additional excellent free educational content for laboratory scientists, as well as the ASCP Workforce Initiatives website, where you'll find this and future Building Bridges content. Again, thank you to our panelists. Thank you so much for everyone who attended, and we wish you a wonderful rest of the day.